Welcome to the Hospital Medicine Unplugged podcast. We are embarking on a deep dive today into the nuanced and often high-stakes world of syncope management. This is really a condition that, well, it accounts for millions in healthcare spending every year, doesn't it? Often because the evaluation and admission decisions can vary so much.
That's right, and our mission today really is to equip you with a structured, evidence-based approach, something solid to tackle the evaluation and management of syncope right there in the hospital setting. We're pulling heavily from the ACA-HR's guidelines, the consensus view, plus recent literature. The goal is always efficiency, isn't it? Quickly finding those few critical patients with underlying cardiac issues while safely and promptly sorting out the benign majority.
Exactly. And before we jump into risk scores and all that, we absolutely have to anchor ourselves to the definition. It's key. When we say syncope, what we mean is a transient, abrupt loss of consciousness. And the mechanism is always that global cerebral hypoperfusion, followed by rapid, totally spontaneous recovery.
Yeah, that definition is crucial. It immediately helps filter out things like seizures, right, where you have that post-ictal confusion, or psychogenic events, which, well, they don't have that true drop in brain blood flow.
And the stakes for getting this distinction right, they tie directly back to mortality. I mean, syncope is common, sure, but the prognosis, it varies wildly.
Dramatically. If the cause turns out to be cardiac, maybe 5–10% of cases, something like that, the patient's one-year mortality risk just skyrockets compared to someone with, say, a simple vasovagal faint. So everything we do in those first few hours really is aimed at finding or ruling out that small but very high-risk cardiac group.
Okay, let's unpack this. Section 1, looking at the three main phases or categories of syncope. Because even though they look different on the surface, the underlying issue is always that temporary drop in brain perfusion below a critical point.
Absolutely. The brain is incredibly sensitive to that. Studies show, consciousness and postural tone are usually lost if blood flow drops for just about 6 to 8 seconds. How it drops, that's what defines the three main categories we deal with. And that, in turn, dictates how we manage them.
Right. Let's start with the most common one, reflex syncope, also called neurally mediated. This is the classic faint. And thankfully, this one generally has the best long-term outlook.
It does. This category comes down to an inappropriate reflex mediated centrally. Basically, the autonomic nervous system kind of mismanages vascular tone and heart rate. So the patient gets this profound, inappropriate vasodilation or significant bradycardia, sometimes a mix of both. And that causes a sudden, steep drop in systemic vascular resistance. Venous return falls, cardiac output drops, and boom, cerebral flow is compromised just long enough.
And within that broad category, there are subtypes that really matter when you're taking the history. There's the classic vasovagal syncope, often triggered by, emotional stress, pain, maybe standing for too long. Then you've got situational syncope. This one is reliably triggered by specific things, like coughing, which jacks up intrathoracic pressure, or micturition, even swallowing sometimes, especially in older folks.
Yeah, and we shouldn't forget carotid sinus syndrome. You see this more in the geriatric population. It's basically a hypersensitive reflex arc. It gets set off by mechanical pressure or movement on the neck, could be a tight collar, turning the head quickly. That leads to an exaggerated vagal response, bradycardia, vasodilation, or both.
And the big clinical clue for all types of reflex syncope, the thing that should immediately lower your worry about a sudden cardiac catastrophe.
The prodrome, absolutely. The patient describes feeling sweaty, nauseous, maybe warm, looking pale. Those warning signs before they lose consciousness. It tells you there was likely a slower, more gradual drop in blood pressure. The nervous system had time to sort of signal what was coming.
Okay, moving to category 2. Orthostatic hypotension syncope. This one often seems straightforward to diagnose, but you really have to nail the measurement technique.
Right. It happens when a patient stands up, and those normal compensatory autonomic reflexes just don't kick in properly. Normally, your baroreceptors sense the position change and trigger immediate vasoconstriction to stop blood pooling in your legs. But if that reflex is impaired, maybe due to autonomic dysfunction, like in Parkinson's, or severe volume depletion, or very commonly medications.
Like vasodilators.
Exactly, vasodilators or diuretics. Then the blood pressure just drops sharply when they stand.
And the strict definition is crucial for the workup. A sustained drop. Systolic pressure down by more than 20 millimeters of mercury, or diastolic down by more than 10. Sustained when moving upright.
And sustained is key. You need to check it over about 3 minutes, right, to make sure it's not just a fleeting dip.
Precisely. Documenting that properly is incredibly high yield. It often points directly to management, like giving fluids or cutting back on blood pressure meds. Okay, third category. And for us as hospitalists, this is the most critical one, cardiac syncope. This is the diagnosis we absolutely cannot miss. It needs admission, aggressive investigation, because the morbidity and mortality risk is highest here.
Correct. This type signifies a sudden, critical drop in cardiac output. We usually think about it in two main buckets, arrhythmic and structural. Arrhythmic causes. Things like severe bradyarrhythmias, complete heart block, serious conduction disease, or sustained ventricular tachycardia.
And emphasizing tachycardia there because it prevents proper filling, right?
Exactly. It prevents adequate ventricular filling time, leading to hemodynamic collapse.
And on the structural side?
There we're looking for mechanical blockages, things that limit the heart's ability to pump enough blood. Think critical outflow obstruction, severe aortic stenosis, maybe hypertrophic cardiomyopathy. We also have to consider acute stuff, like a massive pulmonary embolism or acute MI causing sudden pump failure.
And the key clinical differentiator here compared to reflex syncope.
Often it's the lack of warning, that prodrome we talked about, usually absent. Cardiac syncope tends to be sudden onset, maybe just brief palpitations or some chest discomfort right before, but rarely that full protective warning sequence.
And if it happens during exertion, or crucially, while lying down.
That's a huge red flag. Those circumstances pretty much rule out orthostatic causes entirely and scream cardiac investigation.
Okay, so understanding those three phases really sets us up for section 2, the initial evaluation. For the hospitalist, those first 10-15 minutes, they're absolutely critical. Our main goal, following the ACAAOSH guidelines, is rapid identification of high-risk features, ruling out life-threatening cardiac or occasionally neurogenic causes.
It has to be a structured approach.
Yeah.
Non-negotiable. 3 core components every single time. 1, a meticulous detailed history. 2, a focused physical exam, and again, that must include orthostatic vitals. 3, a mandatory 12-lead ECG.
Let's dig into the history a bit more, because honestly, that's often where the biggest diagnostic clues are hiding. You need to focus on the circumstances. Was it during exercise? That suggests a fixed output problem, like aortic stenosis. Was it while lying down? Points more towards arrhythmia. Was it after a specific trigger, like that coughing fit? And eliciting prodromal symptoms? Super important. Nausea, lightheadedness. That's somewhat reassuring. Complete absence of warning. Alarming.
And don't forget witnesses. The patient might be amnestic to parts of the event. A witness account is vital for differentiating syncope from seizure. True syncope is usually brief, less than a minute, with rapid recovery. Seizures often involve those tonic-clonic movements, last longer, and importantly have that prolonged post-ictal confusion phase.
Right, and ask about tongue biting. Rare in syncope. Incontinence. More common with seizures, though it can happen in both.
Yeah, good points. And then there's the medication review. Sometimes that's the whole story. You have to zero in on antiarrhythmics. They can be pro-arrhythmic. All classes of antihypertensives, really.
Yeah.
Especially things like alpha blockers affecting tone, diuretics causing volume loss.
And certain psych meds, too, right? TCAs, antipsychotics.
Definitely. They can prolong the QT interval, setting the stage for dangerous arrhythmias.
Okay, the physical exam needs to be targeted. Cardiovascular, neurological assessment, obviously. But hammering this home again, orthostatic vital signs are mandatory, unless the patient's in severe shock or something.
And do them properly. Baseline, 1 minute standing, 3 minutes standing. Confirm if that drop is sustained. Also, listen carefully, that classic systolic ejection murmur of aortic stenosis or the harsh murmur of HOCM, those are critical findings demanding imaging.
And the ECG. The 12-lead ECG is required. Every single patient with syncope, full stop. It's probably the most cost-effective tool we have for spotting immediate high-risk problems.
Let's list those high-risk ECG findings, the absolute red flags that mean admission and monitoring, almost regardless of the story. You're looking for Mobitz type 2 second-degree AV block, or complete AV block. That signals severe conduction system failure, risk of asystole, new ischemic changes, ST elevation, depression points to acute MI, any non-sinus rhythm, severe bundle branch blocks, or critically a prolonged QT interval. All raise alarms.
Let's pause on that prolonged QT interval, because it's not just a number on the printout, is it? A QTC, say, above 480 milliseconds, especially if they just started a new med or have electrolyte issues. That flags a real risk for polymorphic VTAC torsades de pointe.
Absolutely. That means urgent magnesium, correcting electrolytes, and continuous monitoring for potentially lethal arrhythmias. The ECG isn't just diagnostic, it's an immediate risk stratification tool, which leads us perfectly into Section 3. The core job of the hospitalist here, defining high risk versus low risk for disposition. Who needs to say, who needs telemetry, who can safely go home.
And we have tools to help with this, right? Clinical decision rules, like the Canadian Syncope Risk Score, they give us an objective framework. The CSRS, for example, assigns points based on history, exam, ECG findings, all to estimate the patient's risk of a serious outcome within 30 days. Things like arrhythmia, MI, PE, major bleeding.
Yeah, and the real value of these scores, like the CSRS, is how they numerically capture the importance of that initial evaluation we just discussed. For instance, it gives a strong negative score, -2 points, if there's a clear vasovagal predisposition or trigger, reinforces the benign nature. But conversely, things like an abnormal troponin or known severe heart failure get high positive scores, clearly justifying inpatient care.
Okay, let's list those features that really push someone into the high-risk category, mandating admission or at least intensive monitoring. These are the signs of instability we can't afford to miss.
First, any known history of structural heart disease,
Mhm.
low ejection fraction, previous heart attack, chronic heart failure that ups the risk significantly. Second, syncope that happens during exertion or while lying flat.
Hmm.
Like we said, strongly points away from reflex causes towards fixed cardiac problems. Third, the absence of those prodromal symptoms. That sudden, out-of-the-blue onset is a major red flag.
And there are other factors too, right? Demographics, associated findings.
Definitely. Advanced age, especially over 60 or 75, is an independent risk factor,
Yeah.
often due to more comorbidities, maybe atypical presentations, palpitations happening right before the syncope, highly suggestive of an arrhythmia. And critically, severe comorbidities need consideration. Active GI bleed causing bad anemia, advanced kidney disease, major electrolyte problems. These can destabilize cardiac function, making the patient high risk.
And of course, any of those high-risk ECG findings we detailed earlier, automatic admission, basically.
Now, flip side, we need to be just as good at spotting the low-risk features. This is how we use resources wisely. A patient might be suitable for safe discharge if it looks like an isolated single episode with a really clear vasovagal or orthostatic trigger, stood up too fast after donating blood, saw something upsetting.
Right. And the presence of those classic prodromal symptoms, the nausea, lightheadedness, sweating, that's strongly linked to a benign outcome. So if they have that prodrome, a normal ECG, a normal cardiac exam, they're younger, say under 60, no other big risk factors, and they recovered quickly and completely, no confusion, no focal deficits, then outpatient management with good follow-up instructions is usually safe.
So our disposition strategy has to be stratified. Hospitalization for the clearly high-risk folks. But there's this big group in the middle, isn't there? The intermediate risk patients. Maybe they're a bit older, maybe the story isn't perfectly clear, but no definite structural disease or critical ECG yet.
Yeah, what do we do with them?
That's where structured observation protocols come in, often in dedicated syncope units or observation areas. These have actually proven pretty effective at cutting down unnecessary full inpatient stays while still keeping patients safe with a period of telemetry, usually 12-24 hours.
That really highlights a key point, doesn't it? Balancing the objective score, like the Canadian score, with our clinical judgment. Sometimes the score might edge towards admission, but the history just screams vasovagal.
Exactly. And these observation pathways give us that bit of breathing room, that extra 24 hours maybe, to confidently sort things out without committing the patient to a multi-day stay and potentially a lot of low-yield, expensive tests.
Which flows perfectly into Section 4. Tiered diagnostic evaluation and using resources smartly. We've established the basics, H&P, ECG, orthostatics are universal. But how do we justify going beyond that?
The guiding principle has to be, testing is targeted by clinical suspicion. Just ordering a routine lab panel on every single person with syncope. Extremely low diagnostic yield. We have to be more surgical about it.
Makes sense. So, for example, check a hemoglobin only if you actually suspect bleeding or severe anemia might be contributing. Troponin only if there's chest pain concerning ECG changes, actual suspicion for ischemia.
Right. Electrolytes if you're worried about significant metabolic issues, bad kidney function, or maybe QT prolongation being worsened by low potassium or magnesium. Otherwise, these routine shotgun labs, they're mostly inefficient, add cost, and rarely change management.
Okay, so that's basic labs. What about the next level? The directed or Tier 2 workup, the stuff reserved for the high-risk patients we identified.
Right. Continuous cardiac monitoring telemetry is essential for pretty much everyone admitted with suspected cardiac syncope or those abnormal ECGs. Arrhythmias are often intermittent, right, by definition.
Yeah.
So telemetry just increases our window of observation, ups the chance of actually catching the culprit rhythm.
And capturing it gives you the definitive diagnosis you need to guide potentially life-saving therapy, like a pacemaker or ICD.
Then there's transthoracic echocardiography, the TTE. That's the go-to Tier 2 test for looking at structure. But again, not for everyone. It's recommended for patients with known structural heart disease already or an abnormal cardiac exam finding, like that new murmur.
Or maybe if the syncope is still unexplained despite them having other high-risk features.
Exactly. You're specifically hunting for things that mechanically block outflow, severe valve stenosis, new wall motion problems suggesting ischemia, maybe a pericardial effusion causing tamponade physiology.
Now, equally important, maybe more important for efficiency, is knowing which advanced tests to avoid routinely. Neuroimaging comes to mind. CT or MRI of the head.
Reserved only for patients with objective focal neurologic signs, or prolonged confusion lasting more than, say, 5 minutes after the event, or clear signs of head trauma from the fall. Doing routine head scans in uncomplicated syncope. The evidence just doesn't support it. Syncope is fundamentally a circulatory problem, not usually a primary brain event.
The yield is incredibly low.
Vanishingly low. Huge waste of resources. Same goes for routine CT pulmonary angiography. Yes, PE can cause syncope, it's a high-risk cause, but unless you have other strong indicators, signs of DVT, hypoxia, tachycardia, maybe a high Wells score, just scanning everyone with syncope PE for PE is very low yield. The prevalence in unselected patients is often under 1%.
So it comes back to targeted testing based on that initial risk stratification, rigorously.
Absolutely, no fishing expeditions.
All right, section 5. We've risk stratified, done targeted testing. Now, management. And the mandate here is clear. Management has to be mechanism specific. Treating everyone the same just doesn't work and can be harmful.
Completely agree. You wouldn't give fluids to someone needing an ICD. Right. So let's break it down by cause. Cardiac syncope. Management here. Prompt cardiology consult is step 1. Non-negotiable. The treatment has to fix the underlying electrical or structural issue.
Which often means devices. Severe bradycardia or heart block needs a pacemaker. Malignant ventricular arrhythmias, especially with low heart function, say EF under 35%, usually needs an implantable cardioverter defibrillator, an ICD.
Right. And if it's structural, that critical aortic stenosis, for example, then timely surgery or maybe a TAVR procedure is needed for survival. You have to address the plumbing problem.
Okay, what about the most common type? Reflex or neurally mediated syncope?
Here, the first line is overwhelmingly non-pharmacologic. It starts with education. Really explaining the mechanism to the patient, emphasizing increased salt and fluid intake, often more than people realize, to keep intravascular volume up, maybe raise baseline blood pressure a bit.
And teaching those physical counterpressure maneuvers, I find patients are often quite interested in those.
They really work. Things like leg crossing, squatting, hand grip, tensing arm muscles. They aren't just distractions. They momentarily increase systemic vascular resistance, squeeze blood back centrally, raise blood pressure by tensing muscles. If the patient recognizes that prodrome starting, doing these maneuvers can actually abort the syncopal episode.
Okay, but what if those don't work for severe recurrent cases?
For that smaller group where non-pharm isn't enough, we might consider targeted medications. Midodrine, that's a peripheral alpha agonist, helps constrict blood vessels, or fludrocortisone, a mineralocorticoid, helps the body retain salt and water, expanding volume. In very select cases, if the reflex is mainly profound bradycardia, pacing might be considered, but that's definitely less common for typical vasovagal syncope.
Got it. And finally, orthostatic hypotension management. This feels like an area where hospitalists can make a big immediate impact.
Absolutely. Step 1 is almost always a meticulous medication review and adjustment. Stop or cut back those offending drugs, diuretics, nitrates, alpha blockers, maybe some antihypertensives.
Makes sense. And non-pharmacologic measures are still key here too.
Paramount. Volume repletion if needed. Avoiding long periods of bed rest. Teaching gradual position changes sit before standing. And compression garments can be really helpful. Abdominal binders, thigh-high compression stockings. They physically reduce that venous pooling in the legs and abdomen.
And if those conservative steps aren't enough for chronic or neurogenic OH?
Then pharmacology comes back into play. Midodrine, again, for its vasoconstrictive effect. Fludrocortisone for volume expansion. Management here is often multidisciplinary too. Getting physical therapy involved early can help with safe mobility training. So Section 6 really brings it all together by looking at prognosis. And this just underscores why that initial risk stratification and finding a cause is so critical. The outcomes vary dramatically.
Yeah, it's a huge gradient. Let's start with the best prognosis, reflex, or vasovagal syncope. Long-term mortality for these patients is basically the same as age-matched controls without syncope.
Right. Recurrence could be a major quality of life issue, sure, and there's a risk of injury from falling, but the event itself is rarely directly life-threatening. excellent prognosis overall.
Okay, orthostatic syncope, how does that compare?
The immediate mortality risk is generally low, much better than cardiac causes. But, and this is but we have to stress the increased morbidity, especially in older adults. These episodes are strongly linked to recurrent falls, fractures, functional decline, even needing nursing home placement.
So the goal of management there is really about preventing injury and maintaining independence.
Precisely. Now, cardiac syncope, this is where the risk is concentrated. Highest risk for bad outcomes.
Yeah.
Sudden cardiac death, major cardiovascular events down the line. We see significantly higher event rates at 30 days, 1 year. It really highlights why aggressive follow-up and fixing the underlying problem, like putting in that ICD, is absolutely necessary. Those interventions actually improve survival.
And then there's the category that often leaves us scratching our heads. Unexplained syncope. After the initial workup, we still don't have a clear cause.
Yeah, the prognosis here is really mixed. It depends almost entirely on those initial risk factors we identified. If the patient is young, no known heart disease, normal ECG, the prognosis is generally pretty good, probably similar to vasovagal. Maybe it was just a weird vasovagal event we couldn't pin down.
But if those high-risk features are present, older age, maybe some subtle ECG changes, known heart disease, even if we didn't catch an arrhythmia this time,
Then even if it's currently unexplained, the prognosis is guarded. These patients might harbor a serious intermittent electrical problem. They often need extended monitoring like an implantable loop recorder and very close follow-up. You can't just assume it's benign if those red flags were there initially. #outro.
Okay, so let's try to summarize the absolute key takeaways from this deep dive. Number one, that systematic initial evaluation, the detailed history, the focused physical with orthostatics, the mandatory 12-lead ECG that is the bedrock. It's how we distinguish the three main types and, crucially, spot the high-risk cardiac patient right away.
Absolutely. And the hospitalist's job is really twofold. First, be hypervigilant for those high-risk features, the concerning history points, the exam findings, the ECG red flags that mandate admission and monitoring to catch dangerous events. Second, and just as vital for using resources well, is actively avoiding routine low-yield testing in low-risk patients. No unnecessary head scans, no blanket CTPE orders, targeted testing only.
And ultimately, management has to be tailored to the specific mechanism we identify. That's what prevents recurrence and improves outcomes.
That structured, evidence-based approach, it saves lives and it saves resources.
It does, but as hospital medicine keeps evolving, there's still this challenge, isn't there? That intermediate risk group. We have pretty clear paths for the very high risk and the very low risk. But how do we, as hospitalists, continue to refine and really validate those structured observation protocols, those pathways that bridge the gap between immediate discharge and a full inpatient admission? How do we best manage that significant, somewhat ambiguous population of intermediate risk syncope patients safely without compromising care, but also without completely overwhelming our already strained hospital systems?
That's exactly right. Refining those syncope observation units, validating the risk scores like CSRS specifically for that intermediate group, figuring out who really benefits from 24 hours of monitoring versus who could potentially go home sooner. That's a huge area of ongoing research and guideline development. It's where a lot of the current focus lies in optimizing syncope care.